Hello, ladies and gentlemen, and boys and girls. I'm Anthony Josephson. I'm an optometrist based at Maskell Josephson in Altrincham in Greater Manchester. Joining me today and hosting me today is Anna Maino, a consultant ophthalmologist who specialises in paediatric specialties. And today we're going to address a few questions and answer a few concerns with regards to myopia management. That's the development and the progression of short-sightedness. What causes it? How does it progress? How can we try and slow it down? And what happens if we do or don't manage to do that?
Yes.
So, Anna, I think you've had a few questions coming through on social media, haven't you? So we'll pass it to you for a sec.
Yes, thank you so much, Anthony. So a first question was, and which we have covered already in our stories, is what causes myopia? And the answer is, we don't know. There are a few theories and they tried a few things, but we don't have a clear answer. We know there are two arms in this condition. One is the efferent arm, so which signal makes the brain want to focus a bit more, and then efferent arm, which molecule actually causes the eye to get bigger. The only clear answer on this is that the role of the mid-retina. So it doesn't matter as much the center of the eye, it doesn't matter as much the periphery of the eye, but the ring in the middle seems to be crucial. And Anthony will cover a little bit about this when we come to the contact lenses as well. The efferent bit is which molecule will cause myopia. Again, a few theories. We haven't really found one specific answer, because, for instance, the molecule in birds is different from the one in other animals, and still they get short-sighted too. However, some interest is on anti-muscarinic drugs, and in particular, we're going to talk about atropine. So one question was, well, let's cover first. So we talked about how we cannot treat myopia. Once you're myopic, we can't do anything to make your eyes smaller. However, what you're talking about are treatments to slow down the progression. So Anthony, the first question for you is there a specific age we need to be particularly careful?
I mean, there's no specific age. Is that we all know that sort of once you get to a certain age, things tend to slow down in terms of progression, or at least slow down or potentially hopefully even stop. So really, the younger you are, the more critical things are in terms of the progression, and often the younger you are, the smaller your arm, so the closer you hold things, and we know that sort of within 30 centimeter distance is likely to accelerate the progression of things. So there's no specific age, but certainly the younger, the better in terms of catching things and slowing things down.
And I also think, as a practical point of view, usually the changes that you see after the age of 25 are smaller. So the change in the prescription of the glasses seems to be much more marked after a certain age. And in fact, most surgeons who do refractive surgery, they recommend to wait until the 18, 20, perhaps early 20s before considering anything, as the prescription can still change.
Yeah, absolutely.
However,
I think that a lot of products that are sort of targeted towards myopia control are targeted at certainly your 6 to 18-year-olds. It doesn't mean you can't do it before, it doesn't mean you can't do it afterwards, but that's the age bracket where people tend to progress the most from the least to the highest prescriptions.
And traditionally, this has been called school myopia because 6 to 18 is the age where most people are at school, and therefore spend a lot. Therefore, they will spend a lot of time looking at things close by. So, if you are older than 25, this applies to you less. And it's still possible to progress, and indeed, there are some people who have a different background for the myopia. And the prescription can still get bigger, but they are the exception, not the rule. And therefore, I will recommend that you have a conversation either with your optician or with your eye doctor. Okay, so we have a talk about the myopia in general. So let's go through the 4 most common methods, at least the one we know in 2021. So the first one that has a lot of interest is atropine drops. Atropine works by stopping the focusing mechanism of the eye. We use atropine 1% in pediatric ophthalmology, either to make children accept a new pair of glasses or to penalize one eye, the good eye, and therefore enable the child who's patching to use the lazy eye more. However, this tends to have a heavy effect for about 6 hours or so. So a lot of studies have been carried out in the Far East on lower concentration of atropine. And it seems that a good balance between low side effect and an effect on the myopia progression is 0.01%. So first of all, if you have heard about it, at the moment, these drops are not licensed in the UK. NICE has not approved them. So this all can change in the future, but as per the 30th of March 2021, it's not possible for an eye doctor to prescribe these drops. Effectiveness depends on the studies. A lot of studies we have are based in the Far East, which is a different population from the UK. And there are a few studies at the moment in London, in Birmingham, in Ireland. So we're looking forward to see what happens in a population which is either UK based or very close to UK based. And I think once we have those studies, chances are atropine drops will also be approved, and therefore we can prescribe them. Success rate is about 50 to 60%. So I would like to stress this is not a magic bullet. It works for some people, for some other people it doesn't. And there is up to 10% of patients for which atropine drop, even a higher concentration, don't work. We don't know why. This patient seems to be younger, seems to have a slightly higher refractive error, and they seem to have parents who were also short-sighted. So maybe the underlying cause for these children refractive error is not only school activities and reading. Maybe they have some genetic components that makes them a little bit worse. In the meantime, what can we do? There are also alternatives that not involve drops, and Anthony is going to talk about them in a minute. So to just give you an advantage, if I can think of one advantage of atropine drops, you can do them at home, and it's relatively simple. A disadvantage of atropine drops, you need to put it every day, and some children might not like them. If you have tried, nobody will know your child better than you do. If you have tried putting antibiotic drops, for some children is a real fight. And another point to consider, like any drops, they can have side effects. The most common one is photophobia, i.e. the children are very sensitive to light. Some optometrists will recommend photochromatic lenses. And some of the children might even become allergic to atropine. So Anthony, can you talk us a little bit about an alternative? So let's start with Ortho-K.
Okay, so Ortho-K is orthokeratology, and basically that's a hard contact lens. It's a gas permeable contact lens. It's a lens that looks, if I can get it in any sort of concentration near the camera, like this. Now, these lenses are generally about 9 millimeters in diameter. Compare that to a conventional soft contact lens that most people will be more familiar with. They're about 14 and a half millimeters. So a gas permeable contact lens will sit within the margins of the cornea. The purpose of orthokeratology is that it remolds on a temporary basis the shape of the cornea, and not the whole cornea, just the central portion of it, which is a big part as to why they're successful in myopia control. By remolding the central part of the cornea, what it does is it flattens the shape of the eye and effectively changes the focal length of the eye and basically neutralizes the effects of the myopia. That means that once you've taken the contact lens out, you've got hopefully pretty good, clear 20/20 or 6/6 and better vision throughout the day, because these lenses are lenses that you actually pop in during the night, sleep in them, recommended at least sort of 6 hours in them, wake up, take them out, and then hopefully during the day you don't actually need any glasses or any contact lenses in order to see things, certainly in the longer distance.
It sounds great, but I think it doesn't suit everybody. So am I correct in thinking there is an upper limit of refractive error? So not every myope can use this lens?
Yeah, absolutely. I mean, obviously nothing suits everybody, but in terms of the prescription parameters that are possible for these contact lenses, is that most manufacturers will sort of throw around -5, give or take a little bit, in terms of what prescription it goes up to. And there's also limits on the amount of corneal astigmatism that it can compensate for or correct for as well. So generally, if you're approaching -6, or if you've got more than 1.5, 2 diopters of astigmatism, you can definitely expect there to be limitations. Now, there are obviously possibilities that if you're a -10, that you can wear these sorts of contact lenses to compensate for -6 of your prescription. It will effectively reduce your prescription, and you can therefore wear conventional glasses or conventional contact lenses during the day afterwards to correct the residual prescription. You've still got the alteration to the shape of the cornea as you would have done by wearing the contact lenses anyway. So it will still likely slow things down, but a lot of that depends on what your prescription is and how much defocus there is at the edges versus the central portion.
And obviously for people who are just, they want to ask this question is, if you are a child, you will need the parents to help out in putting the contact lenses in.
To some extent, I guess it depends on how mature, how old the child is, how dexterous they are. Is that it's not uncommon for us to fit 6-year-olds, 7-year-olds with these sorts of contact lenses, and once we've spent a little bit of time teaching them how to do it, we generally leave it to the kids to do. The parents will often supervise them to begin with, but the kids are generally pretty good at doing it. So, same as sometimes we have 10-year-olds, 11-year-olds who just can't manage it without their parents. I guess it's one of the benefits of these contact lenses over other lenses that we'll no doubt be touching upon shortly, is that the actual insertion or application and removal of the contact lenses is done just before bedtime and just after bedtime. So it's not impossible or implausible to get parental help or supervision when it comes to handling these sorts of products.
And another question is, what are the possible risks of these lenses?
There are risks with everything. There are risks with wearing any sort of contact lenses. There are risks with sleeping in any sort of contact lenses. So whilst these contact lenses are permeable to oxygen and breathable enough in order to be licensed and approved for sleeping, and there is always a risk associated with sleeping in contact lenses. Good compliance, so that's washing your hands, keeping your fingertips clean and dry, using the right cleaning solutions, cleaning your contact lenses, and basically just generally looking after your contact lenses properly will obviously reduce the risk of those sorts of infections. But that's the main complication, because effectively, if it doesn't give you what you want from a vision point of view, or it's not satisfactory from a vision point of view, you can just stop wearing the contact lenses, and then gradually over a matter of days, your cornea will rebound back to either its original shape or what its new shape would be, depending on how long you've been wearing them. And you will then have all conventional or other options available to you.
Okay, and now let's move on to a different type of contact lens, which is called center distance multifocal contact lens. Can you talk us a little bit about these?
Yeah, so the center distance multifocal generally involves soft contact lenses, and that's kind of what one of these are. So we touched upon it a little bit earlier in terms of the diameter of these being a little bit bigger. So it's about 14.5 millimeters, 14 millimeters in diameter, the whole contact lens. Now, multifocal contact lenses are not a brand new thing. They've been around for a little while, and broadly speaking, they were created or designed for presbyopia. So people 40, 45 plus who are starting to struggle with their focus adaptation and changing from distance focus to near focus. In other words, people who are starting to feel that they need reading glasses, or in the case of myopic people, those who are starting to slide their glasses down their nose, look over the top, or just change their prescription by doing that sort of thing. So these contact lenses were designed to do that. And the vast majority of them are center near lenses, which will give you a central focal point, which is designed to help with reading. It works for a lot of presbyopes, but it's not what we're here to talk about in terms of myopia control. Center distance puts the distance prescription in the middle of the contact lens, and effectively, in myopes, the prescription will reduce towards the edge of the contact lens, and in theory give you a little bit more help towards the near distances. And it's this defocusing towards the mid periphery and the further out parts of the contact lens, which is how the orthokeratology works, how these lenses work, and how glasses work, that we'll go into no doubt shortly. And it's that defocusing which is essential for trying to slow down the axial length growth. So in other words, trying to stop or reduce the speed in which your eyeball is actually elongating, and in doing so, reduce the progression of your myopia. So these contact lenses have been around for quite a while under presbyopic purposes. It's only over more recent years that they've started to get approval specifically to be prescribed for myopia control. Now, undoubtedly, optometrists have been prescribing them to kids prior to the approval under different names and different materials and different modalities. And a lot of that comes down to the fact that whilst never officially approved, optometrists have been giving varifocal glasses and bifocal glasses for a long time, longer than I've been doing this, which is sort of 14 years or so now, in order to try and slow it down. They're sort of a bit more archaic technologies now in terms of myopia control, but these contact lenses are designed, whether it's a daily disposable or a monthly replacement contact lens, they're designed to basically be put in and worn throughout most of the day and most of the days in order to offer you the benefits of myopia control.
So in summary, instead of wearing the standard contact lenses, which is the one I have now, if you have a child who's already wearing them, it will be a good idea to switch to these, because to the child it will not look any different or feel any different from a standard soft contact lens. However, they will benefit from having the mid-periphery defocused. Is it correct?
Yeah, that's correct. Now, again, there are limitations. Is that certainly the prescriptions in these are pretty good. They go reasonably high in terms of minus, but there's no standard prescription available in these. Certainly in the myopia control approved contact lenses that correct for any form of astigmatism. So you're automatically limiting the availability of these sorts of products. But yeah, they'll feel the same as normal contact lenses. They'll handle the same as normal contact lenses. Certainly, you'd look after them the same as you would do normal contact lenses. The issue comes down to the fact that there are fewer parameters available compared to normal contact lenses. And because you have got this multifocal design to them, some people will find that the actual focus and the vision through them is slightly more compromised than normal contact lenses. So it's always a really, really good thing if you're not used to any contact lenses to go into these, because you've got nothing to compare it to. But for those who are used to contact lenses, it's an adaptation period, and it's very unlikely that you'd struggle to adapt, but they can certainly feel more compromising than your standard lenses to begin with.
And that's also true, for instance, for people like me that are used to just glasses, single focal glasses, and then if you get a pair of varifocals, it might be different. So there is always an adaptation period there. However, we need to say that if it doesn't work for you, you can always stop and switch to a different type of contact lens. It's not a permanent change or anything like that. And also in terms of complication and risks, as Anthony said before, is the same risk of of using standard contact lenses. You have to be careful with hand hygiene in the same way you will do with standard contact lenses. And finally, the fourth mechanism, which is relatively new and is the reason why I thought it would be a good idea to talk about this, is multifocal glasses. Now, can you talk us a little bit about these?
Yeah. So I mean, I briefly touched on prescribing bifocal, varifocal glasses for quite some time. Now, they're your conventional multifocal glasses. Now, regardless as to what people think historically in terms of, yes, they help slow things down, that's not what we're here to talk about, and that's not licensed or approved for myopia control. There's a very, very specific lens product available, and we've avoided names of things so far because there are various brands that do what we've spoken about. There is only in the UK at the moment one product, which is a lens that's called MyoSmart or MyoSmart, manufactured by a company called Hoya, and this is one of the uncuts of those lenses. So there's a little circle in the middle that you'll briefly see there. Now that's just so that we can position these lenses correctly. Now the idea of this is that would get cut down into the shape of a person's glasses, and that little circle is the diameter of where your full distance prescription would be. So whatever your prescription is, whether it's minus a half a unit or minus 4 units, whether you've got half a unit of astigmatism or up to 4 units of astigmatism, these can correct up to minus 10, including 4 units of astigmatism. Just around that little circle, there's an area of defocus, which Hoya refers to as their DIMS technology. And effectively what that does is it provides lots and lots of little lenslets and teeny little sections going around that circle, which are effectively plus 3.5 power lenses. So if your prescription was minus 3.5, they would effectively be 0. If your prescription was minus 2, they'd actually have a plus power to them. And the whole point of those little lenslets and those little eyelets is that effectively when you're looking through the clear bit in the middle, they're providing that defocus a little bit further out, which is what's been proven to slow down the axial length growth and reduce the progression, hopefully, of the myopia.
That's excellent, Anthony. Thank you. And something also is worthwhile saying is the advantage of multifocal lenses is that you don't need to wear a contact lens. So if you're worried about infections, or if you're worried about sleeping with contact lenses, or if your child or yourself are not happy with wearing contact lenses and people can't tolerate them, that's just a pair of glasses. So it's easier from that point of view. And something that is worthwhile saying, because we need to be fair, is there is no runaway winner. So all these 4 methods have similar success rate, which is between 50 and 60%, if I understand correctly, Anthony. Is it correct?
Yeah, I mean, pretty much all of them will hopefully slow down the progression by around 50 or 60%, give or take. But obviously, there's no fast and steady rules. Is that we'll see people who over a few years show very little progression, and we'll see people who show a fairly rapid progression, even using one of these products. And you honestly can't say whether it would have got quicker without. You can't prove whether it's actually working or not on any given individual, but they're all averaging about 50, 60% of progression slowdown compared to what they likely would have experienced without it.
And something else is also something else that also we should mention is there is research now showing that there is an additive effect. So people who use Auto-K, and despite them they see an increase in their myopia, they might want to consider a second treatment on top of the Auto-K, or people can mix and match atropine and glasses, or atropine and contact lenses, and so on, or perhaps wearing your Auto-K in the night and then the glasses during the day. So it's still relatively new, and it's worthwhile exploring all these possibilities. And we will know, of course, more. Something that I did mention in my story yesterday is amazing how science changes, and people have to understand this is all about science. So we say something today because we have evidence to back it up today. but in 10 years, it might be something completely different, which doesn't make us stupid today, but it will be good to know things in advance. An example is, I'm much older than you, Anthony. So in my day, when I was a teenager, I was undercorrected. So my optician and my eye doctor recommended a slightly less prescription. The idea was at the time to slow down the effect of the progression. But now we know this is actually a very bad idea because it makes it worse. But yes, it will be good to judge, with the benefit of 20 extra years of eye research. Another thing that was fashionable at the time was to sleep with the night light on. Because there were some studies about the effect of light and so on. Well, and now this is now not used, and it's not advised any longer. One final question that we had from our followers is, assuming that you are older than 25, so now you are already short-sighted, and we spoke about in our stories how being short-sighted will put you at higher risk of retinal detachment, changes at the back of the eye, glaucoma, and all these will lead to and all this will lead to sight problems. Is there anything that people can do to decrease the chance of developing a retinal detachment, for instance?
No, is the simple answer to that. I mean, there's nothing that you can do in terms of trying to reverse the changes in the prescription. There are obviously lifestyle things that put a person more at risk of retinal detachment. So if you're involved in fairly aggressive contact sports, you're far more likely to have a retinal detachment at any age. If you're throwing yourself off a bridge with an elastic strapped around your ankle, you're far more likely to suffer things like retinal detachment. So there are certain things that should be avoided if you're considered at higher risk anyway. But in terms of, I'm 40 years old, 50 years old, I'm highly myopic, what can I do to reduce my probability or possibility of a detachment? It is almost entirely lifestyle related, as opposed to any of the options that we've spoken about today.
So it really is not the time now to take up cage fighting or anything like that?
No, I wouldn't suggest that. I mean, I'm not going to encourage many people to do that at any age, but I wouldn't encourage people to do it if they were worried about having a retinal detachment. It's one of the things to keep fairly low down the risk.
That's brilliant, Anthony. Thank you so much for your time. And to our followers, if you have any other questions you'd like to ask us, please send us a message.
Thanks, Anna.
Thank you. Bye.
Yes. Bye.